It's not a question per se, but it's a concern. I hear patients telling me that they haven't had a biopsy, but they've got a confirmed diagnosis of prostate cancer. And I take issue with that because I think it's a tissue-based diagnosis. And while the multiparametric MRI may be really helpful in deciding where to biopsy, I don't think it's appropriate to tell a patient he has prostate cancer based on simply the multiparametric MRI. So
I couldn't agree with you more. It's so important for us to know what somebody's Gleason score is, even if somebody has a PSA. And I'm actually seeing a patient right now in my clinic who his PSA is 150. His MRI shows invasion of a tumor into the seminal vesicles. He has enlarged lymph nodes on MRI. And, we still absolutely need to have the tissue diagnosis to go ahead and, start the appropriate treatment. And so, I would never advise anybody to do anything until we have a prostate biopsy, which shows what's really going on. So I think that's a great point. Yeah, thank you.
Merel, do you have another question?
Nope, that's it for now.
Okie dokie. Paul, what about you?
There is an issue. Thank you very much for being available to us, Dr. Lee. There's one question that comes up, a type of question in support groups quite a lot, and I think as a physician you must face something similar, and that is how to communicate effectively with a patient who may be unable to grasp nuances of probability. They just want a black and white answer. And when the actual answer is, well, there's an 86% chance that if you continue on active surveillance, you'll live on into your 90s. But the patient doesn't understand what that means. Any suggestions?
Oh, it's a very, it's a tough situation. I look at my role as an educator. I think it's so important to spend the time that it takes to really help somebody to figure out what all of this information means. But not everybody has the same experience level with looking at these types of things, and so it's it can be a challenge. But I think it can be as simple as trying to explain what somebody's batting average is in baseball. That can be a nice kind of understandable type of corollary that can help some guys to see what these percentages mean. But I think there are a lot of guys who will really take the time to figure it out, but then there are other guys who, they're just too nervous about it. And so, I think it is the role of the physician to give the best advice that you can. If knowing what I know, I can help somebody to figure that out, even though they don't best understand it. If that's the way that I would treat my brother or myself or my dad, and I feel like that's really the best way to go, then, I think that behooves everybody to advise patients who have a difficult time figuring things out on their own.
Well, I understand. Do you mind if I ask a follow-up question?
Oh, please do, yeah.
I was a little surprised when you said that 90% of Gleason 6 patients will have no problem, but the 10%, and I had thought the figures were closer to 98% and 2%, which makes quite a difference, I would think. I wonder if you could comment on that, or if maybe I've got my facts wrong.
Yeah, no, I think it's Gleason score is very important, but I think it depends on what kind of time frame that you're looking at. I think the 98% is very applicable for the 5-year time frame, but that's probably a more accurate number than the 90%. But the 90%, I use very often to just help patients to realize that they have a really high percentage chance. But I think sometimes if you paint an over rosy picture, it can be difficult for patients to appreciate that. You may not have a good outcome.
Right.
And so for those patients who do have a bad outcome, it's 100% for them. And so, that really kind of clouds everything and makes it really difficult for those patients to understand sometimes.
So, we are, I think, so for clarification for the audience, talking both about the risk of upgrading between biopsy and actual surgical procedure, if surgery is what is carried out, and also quite separately the risk that a Gleason 6 cancer will progress to Gleason 7 over time. Is that correct, Dr. Lee?
Yeah, and then another point that I could make to address your question was that, the guys who we do the operation for who have a Gleason 6 on their initial biopsy, when we get their final pathology reports, they'll end up with a Gleason 7 afterwards, a good 35% of the time. So, I think I'm framing my reference point more to the biopsy outcome rather than the final pathology report outcome. Yeah, because when I talk to patients about their final pathology reports, if they have a Gleason 6 on their final pathology report, then I'll tell them there are 95 to 98% chances of being great at 10 years. But with such a significant upgrading percentage that we see for guys with Gleason 6, I think that changes your overall percentage of guys who walk in your door with a biopsy report that shows a Gleason 6.
I absolutely understand. I entered the surgery with a Gleason 7, and the pathology report said Gleason 9, which was something of a shock for me.
Yeah, right. Yeah, and we definitely have had our share of those guys too. So it's really.
Thank you.
So
no, thank you.
Thank you, Paul. Tony, do you have a couple of questions?
Yes, I do. Again, echoing Paul's comment, thank you, Dr. Lee, for coming on the show. My questions are going to run into a little bit more of the genetic biomarkers that we have, the exciting new genetic biomarkers that we have, and we're seeing them used in a great deal of access prior to an active therapy to make a determination that the patient is maybe good candidate for active surveillance or more likely for aggressive. And then also to come back on around after the prostatectomy. During the post-prostatectomy, do you use these tests on the sample tissue, and where do you use that information if you do?
Right. No, and thanks for asking that question. I didn't, in my little opening remarks, I didn't get to talk about the post-prostatectomy setting, and we do for all the high-risk guys, get them a genetic test afterwards. And your two options in that arena right now are the Polaris test, which we talked about for the biopsy situation, but then also the Decipher score. And so the Decipher score, I think, it's a very interesting test. The company uses a chip which actually tests for 1.4 million different gene products, but they've found 22 in particular, which can help stratify the guys into different, chances for having metastatic disease in the long run. So we order one or the other tests for all the high-risk guys and a good number of the intermediate risk guys when we see that on their final pathology reports. And so we use that information quite a bit to help guide the patients to decide whether they want to do actively follow their PSA or do adjuvant radiation, or do salvage radiation, by continuing to monitor their PSA and see how that progresses over time.
Beck, on the genetics again here, it's an exciting new field that we're finding over at SWOG, where we're taking the outcomes of some of the large trials that SWOG has been able to do, such as the SELECT trial, the PCPT trial, going back on over and reviewing backwards at and reflecting on outcomes, and perhaps, hopefully, identifying hypotheses for specific genes for specific patients. Do you guys participate in that type of activity as well? I mean, I know we do on the reflection side here, but perhaps prospectively, what are you guys doing?
Yeah, so we're keeping. So I have a database of our 4,500 guys that I've performed robot prostatectomy for, and we're following all of these guys who have had the genetic testing. We have an active tumor tissue banking program as well, which we could potentially get information out of. And so, we're trying to prospectively collect this data.
Okay, thank you very much.
So, Dr.
Thank you.
I'm curious. You mentioned the use of either adjuvant or salvage radiation in high-risk patients. The general perception seems to be that we are starting to see a great deal less adjuvant therapy and a great deal more very early salvage therapy in people being monitored with ultrasensitive PSAs. Does the Decipher test help you to tell who really does need the immediate adjuvant radiation?
No. So I think this is one of the most interesting studies that has come out regarding the genetic tests recently. The Decipher test was looked at for a group of patients from the Mayo Clinic and at Jefferson who underwent prostatectomy and then either underwent adjuvant or salvage radiation because they had high-risk features. And the Decipher score was actually able to show that guys who had very high-risk features did better when they got adjuvant radiation versus early salvage radiation. So it's interesting information. I think it needs to be validated on a bigger scale because I think it was still only about less than 100 patients in the study. But I think this is a potential aid to help guys to figure out whether they should undergo that adjuvant radiation.
And the other thing that interests me is we are starting. I mean, with the coming of the 11 choline PET CT scans and some other forms of imaging that are becoming available, we're starting to see the possibility of being able to look at patients pre-treatment to decide whether surgery is even a good idea at all, or if done, should be done in combination with hormone therapy or whatever, for men who might have very small amounts of cancer that have already reached the lymph nodes or even other areas in the pelvis. Do you have any experience yet with using some of these new tests in scenarios like that?
Yeah, so at Penn we've started using the sodium fluoride PET scans on a limited basis. I think the pictures that we obtain are really beautiful, but as to actually altering treatment decisions so far, we haven't really come to that point yet. One of the things that we are seeing recently, I think it's because of the decrease in screening that's gone on over the past few years, is that we're starting to see more guys with higher risk disease pop up. And so I think there is an increased interest for these guys with high-risk disease, though, to go ahead and get radical prostatectomy, even in the face of low-volume oligometastatic disease or, some enlarged lymph nodes which may be suspicious for metastatic disease, but with extended lymph node dissections, we can potentially remove those lymph nodes. There have been some small case reports which show that men do very well for many years, even in the face of high-risk disease in this setting. So I think the indications for surgery may be slightly expanding with this increase in high-risk patients that we're seeing.
And I suspect that I'm not the only panelist who's seen at least a couple of papers on new forms of technique that will actually allow highlighting of cancer or of cancerous areas. One might call it glowing in the dark.
Right.
As a method to actually improve the quality of surgery. Are you familiar with any of those techniques?
Yeah. So we use a similar type of technique for kidney tumors with fluorescent. So it's called ICG. You can inject that into patients during your robotic partial nephrectomy, and then with the aid of the laser fluorescence technology that's built into the robot, typically the kidney tumors will be slightly less vascular. So then you can actually see as you approach the tumor whether you're getting too close. With prostate cancer, it's, I think the potential benefit would be if you could give somebody some type of immunofluorescence, which would actually tag on to PSMA that's expressed on the surface of prostate cancer cells, inject that preoperatively, and then allow that to, go through the body and potentially latch onto lymph nodes that have small volume prostate cancer, and then using a similar type of laser fluorescence and actually visualize where these small tumor deposits are. I think we're still a ways away from that. I think there are actually other organ systems like kidney where this is actually being used clinically, but for prostate, to have a definable target that's very reliable, we're still not there yet, unfortunately. But yeah, the technology is